CNS infection number 4, prepared by Prof. Sharaf and revised by Prof. Rami Edward. We'll deal with some miscellaneous conditions. First is rasmussen encephalitis, which is an autoimmune response to viral infection before occurs in children and usually presenting with sudden onset of epilepsy due to progressive atrophy of the cerebellum. Here is the appearance. You will find progressive atrophic changes on one side, hemi-atrophy, cerebral hemi-atrophy, including also not only the cortical sulci but also the self-facial and operculum and insula. So this is rasmussen encephalitis and autoimmune response. ADEM, which is acute disseminated encephalomyelitis, is another immune response occurring post-viral infection 1 to 3 weeks after infection. This will start as widespread cortical and medullary or both gray and white matter infection, immune response resulting in swelling and hyperintensity on T2 and the flare. It's a white matter disease, variable enhancement, can be hemorrhagic, and it involves all parts: cerebrum, cerebellum, brainstem, cortical, subcortical. It is a widespread disease. Here is another case of ADEM with multiple infarct-like and hemorrhagic changes. Another ADEM with multiple T1 and T2 hemorrhages, T1 and the flare patches with hemorrhages. Progressive myeloencephalitis, CT may show low attenuation region but could be normal. Low intensity at T1 and high intensity in flare and T2. Changes in the white matter and the cortex of both cerebral and cerebral hemispheres. Laboratory findings are diagnostic. Causes are similar but to a less extent, less than in bacterial infection, and it has a better prognosis. This is progressive myeloencephalopathy involving the right corona radiata, and there is an incidental arachnoid cyst here. This is a lesion and this is incidental arachnoid cyst. Progressive multiple leukoencephalopathy. Five years old with acute onset epilepsy. These last two are 2 months after. We have here an area of increased intensity, both in T1 and in T2 and flare. In CT it could not be seen. 2 months later it resolves. This is subacute necrotizing pancreatitis, which is due to reactivation of measles virus. It's multifocal cortical and subcortical lesions, bilateral or unilateral, and may progress into involving corpus callosum, and usually it disappears. Here is another one, subacute necrotizing encephalomyelitis appearing as hyperintensity 2 and hyperintensity flare, subacute necrotizing panencephalitis involving most of the brain parenchyma, mainly the left occipital and to a less extent the right occipital region. Another example of subacute involving the cerebellum and resulting in cystic encephalomyelitis. Now this at 0 line, this is 2 months and this 16 months. In 16 months we have now the cystic encephalitis, cystic encephalomalacia, and we have hydrocephalic changes, both due to shrinkage and both due to obstruction due to meningeal obstruction of the exit foramina. Subacute necrotizing panencephalitis. Reactivation of measles virus. This is one of them, and this is another one which progresses into cystic encephalopathy and cystic encephalomalacia and hydrocephalus. Reye syndrome is something related to urea cycle defect, something it is post-viral again. It results in cerebral edema of the diffuse pattern, diffuse cerebral edema, severe encephalopathy. There is fatty liver and there is kidney involvement, and here is the appearance. It is Reye syndrome. Fatty liver and kidneys, post-viral etiology, exogenous toxins, or urea cycle defect. Mortality is high. Reye syndrome. Hemolytic uremic syndromes, acute encephalopathy due to microangiopathy, and the other one is BRIS or the posterior reversible encephalopathy syndrome. These two are related to uremia, chronic renal failure. Hemolytic uremia syndromes. It's not evident, but maybe you can notice that there is something posteriorly. There is some swelling of the gyri posteriorly. Press. Now come to meningeal enhancement. It either leptomeningeal and pachymeningeal. Meningeal enhancement can occur with any process that irritates meninges. The leptomeningeal involves the pia and the inner layer of the arachnoid. The pachymeningeal involves the dura and outer layer of the arachnoid. A lot of causes: infection, tumors, sarcoid, subarachnoid hemorrhage, infarct, neurocutaneous disorders like Sturge-Weber and rheumatoid arthritis all can produce leptomeningeal enhancement. And as we said, leptomeningeal enhancement, that means involve the pia and the inner layer of the arachnoid, while the pachymeningeal are the meninges, true meninges, that is the outer layer of the arachnoid and dura. Pachymeningeal or dural enhancement, again due to a long list including infections, tumors, intracranial hypotension, and many other conditions. Differential diagnosis of nodular meningeal enhancement is carcinomatosis, meningitis, and sarcoid. Carcinomatosis, meningitis, and sarcoid. Sarcoidosis can produce this type of nodular masses along the falx. Same appearance. So we have mainly this to remember. The differential diagnosis of nodular meningeal enhancement is leptomeningeal carcinomatosis, meningitis, and sarcoidosis. Thank you.